Good afternoon, everyone. My name is Dio Cavaleritos. I'm faculty at Emory University, and I had the pleasure of chairing the recent CFF-sponsored committee that produced the 2020 Models of Palliative Care guidelines that we'll be talking about in today's session. I have no relevant disclosures other than research support from the CF Foundation and the National Institutes of Health. By the end of today's talk, I'd like for you to be able to define and describe what palliative care is and isn't, to think about various models of delivering palliative care, whether that is palliative care from a palliative care specialist, as well as the role of CF care teams in providing primary or generalist palliative care themselves. And all the while, we'll be doing that by reviewing the 2020 guidelines and seeing how those apply to the CF care team, as well as the larger CF community. So before we get started, I'd like to level the playing field and make sure that we're all on the same page about what palliative care is and isn't. When I think of palliative care, I first start with an overall approach or philosophy of care, thinking about how do we improve quality of life and reduce suffering for people with life-limiting illnesses like CF. And when we think about what sort of palliative care is, we think about intervening upon those various insults to quality of life, whether they're physical symptoms, whether they're psychosocial or existential or spiritual concerns, whether they're concerns about managing intense treatment burden with someone's roles like providing for their families or finishing their education. We think about how do we understand who we're serving? How do we understand their hopes, their fears, their goals about their future of their illness and the treatments that sort of lie before them, and how do we operationalize their goals of care into the tangible care that they receive, whether that's advanced care planning or discussions with their team, so on and so forth. We also think a lot about how do we provide support to caregivers, whether those are family members or friends or whoever else is in the community that is supporting people living with CF. And in order to do this, this really requires goal concordant, patient-centered, and highly coordinated care across teams. And so really to do that, we need to promote effective communication across the various clinical entities that will take care of and support people living with CF. Now, all of that sort of comes together and we call all of that palliative care in terms of the philosophy of care. On the next slide, I'll talk about sort of more nitty-gritty what various delivery forms of palliative care look like. But when I talk about palliative care, I do want to be really clear that we're talking about palliative care that can be initiated at any point in the illness trajectory. Oftentimes, we might hear some reservations or hesitation about getting palliative care involved. You might hear somebody say it's not time for palliative care, or we haven't exhausted all treatment options, therefore palliative care isn't appropriate. And I want to pause for a second and mention that that is unfortunately a misconception about what palliative care is, and that is a conflation of palliative care with hospice. So for those of you who might not be familiar, hospice is a very intense form of palliative care that we reserve for people who are expected to live no more than 6 months. Now, palliative care for the rest of today's session, we'll be talking about early palliative care. We'll be talking about palliative care, again, that can provide support for those aforementioned bullet points throughout the entire disease trajectory. So whether that is at the point of birth, whether that is at childhood, whether that is at the end of life, but really thinking about how do we optimize care, how do we improve quality of life, and how can we reduce suffering for people living with a life-limiting illness, regardless of their prognosis. Now, I mentioned that there are sort of two overarching delivery models of palliative care, and it's pretty simple once I explain it. So we really think about specialist versus primary palliative care. When I think about specialist palliative care, I'm talking about palliative care that is delivered by somebody with a fellowship or other advanced training in palliative care skills. When I talk about primary or generalist palliative care, I'm thinking about any clinician providing sort of basic or first level attention to suffering that people might be experiencing. So an analogy that I often use is psychiatry. So if I were to go to my primary care provider's office and say that I'm having concerns about depression, they might start me on an antidepressant. And if I don't respond to that therapy, if that therapy doesn't work for me, I might then be referred to a psychiatrist for that enhanced training or that expertise. Similar concept here. So a CF clinician, by virtue of their long-standing and really intense and beautiful relationship with people living with CF, might pick up on sources of suffering and might provide first-line therapies, which oftentimes CF clinicians are already doing. And we recognize that as a primary palliative care role. And then what we'll also be thinking about is how do we leverage palliative care specialists to support both people living with CF as well as their CF care teams to address these sources of suffering. So as I've mentioned, and hopefully motivated up until this point, there is a role for palliative care in CF, right? When we think of palliative care, we think of palliative care as being indicated for people with a life-limiting illness. Of course, CF is one of those. And we know that people with CF experience suffering in a variety of different ways throughout their illness experience. And all the while, they're making complicated decisions about high risk, potentially high reward treatment options, for example, transplant. And so how do we think about bringing in an extra layer of support to operationalize those care goals and also meet the needs of people living with CF so that their quality of life is optimized throughout their entire experience? So all of that motivated us to publish in 2020 in the Journal of Palliative Medicine, evidence-informed consensus guidelines regarding various delivery methods of palliative care in the CF experience. We published a total of 11 recommendations split out into these 3 key domains that you can see on the right-hand side of your screen. 5 recommendations regarding primary or first-line palliative care, 3 recommendations about when and how to involve palliative care specialists, and 3 recommendations regarding how do we identify unmet palliative needs in the CF community. So without further ado, let's jump into that first domain, which is primary palliative care in CF. So our first recommendation, as I'll read here, is the CF Foundation recommends that CF care teams deliver primary palliative care as part of usual CF care at the time of diagnosis and throughout the disease course. So again, this concept here that high quality CF care in and of itself does require attention to palliative domains, and that primary palliative care doesn't require trigger events like, for example, treatment futility or the idea that there are no other treatment options available. But really, we should be thinking about how do we identify palliative needs and how do we operationalize, again, that first line palliative support throughout the entire trajectory. And as I mentioned earlier, much of usual CF care is already primary palliative care, whether that is symptomatic, whether that is having deep conversations with patients and their families about what they wish for and hope for regarding their care. All of that is palliative care, and we're recognizing that as primary palliative care. Our second recommendation responds to the need that we heard from the CF community that CF care teams do need enhanced training in primary palliative care skills. So I did not mention this, but we had done some survey work with the CF community, including CF care teams. And what we heard overwhelmingly was a desire for training in primary palliative care skills. So we, as you can see from the recommendation statement, the CF Foundation recommends that CF care team members receive primary palliative care training relevant to their discipline and employ these skills within their scope of practice. So really thinking about the fact that every CF care team member has a role in identifying and addressing suffering in various ways, whether that is a respiratory therapist, a dietitian, a nurse, a pulmonologist. Everybody on the team will interact with people with CF and their family members in different ways and might pick up on various sources of suffering that then we can address as an overall team. But that requires additional training to be able to know, how do I address this symptom, for example? How do I start this conversation about goals of care? Importantly, CF care team members have a critical role in eliciting goals of care and really understanding what matters most to the people that they serve. So the CF Foundation recommends that CF and transplant care teams engage individuals with CF and their caregivers in goals of care discussions and advanced care planning across the lifespan. So really thinking about, again, the role that CF care teams have in understanding the hopes, the fears, the values, and the wishes that their patients with CF and their families have. And as we know from the literature, there's oftentimes a delay to have these goals of care discussions until late stages of disease or at the point of transplant, for example. And really, we also do have some data that suggests that people with CF are willing to have these important discussions much earlier on. And so how can we think about engaging individuals with CF and their families to have these ongoing discussions about their values and their hopes regarding their care over the course of their disease, recognizing that those might change over time and that their care has to change to reflect those wishes and those goals as well. When we do get to the point of thinking about end-of-life care, we do want to reiterate that the provision of end-of-life care does require a collaborative approach between CF care teams and palliative care or hospice teams, for example. Thinking about how do we provide high quality, intense symptom and other types of support to people with CF and their families. We know that from the literature that the use of hospice is quite low in CF. However, there are some data that show that it is associated with higher quality of care. So again, how do we leverage hospice care so that it is provided at the first possible moment that it is appropriate for people with CF, and that we don't wait too late to get hospice involved when it is indicated? Importantly, we know that people with CF are supported by caregivers, loved ones, family, and other community members, and that those individuals might require support themselves from the CF care team. So the CFF recommends that CF care teams identify and address caregivers' concerns and provide support and resources outside of the CF care team when appropriate, from diagnosis through bereavement. So again, recognizing that those roles of caregivers may fluctuate throughout the experience, and that those periods of high need might then translate into some additional support from the CF care team, or potentially from a palliative care service or a psychology service, for example, whatever those needs may be. And so how do we assess those needs? That requires continuous monitoring and intervention, which we'll talk about in the last bucket of recommendations regarding screening and assessment. So next, moving on to the set of recommendations that correspond to the role of palliative care specialists in CF. So the CFF recommends that CF and transplant care teams consult palliative care specialty clinicians and other specialists to address that palliative care needs that extend beyond their expertise, facilitating seamless communication pathways between and among teams. So really thinking about what are the points in the illness experience when a palliative care specialist makes the most sense and can optimally support CF care teams and patients and families. So here below, we offer some some reasons that palliative care specialists may be involved, but this is not an exhaustive list by any means. But for example, when unmet needs are identified that exceed the primary team's expertise. So for example, let's think back about the psychiatry example that I gave earlier on. Again, that analogy can be easily applied to CF here. When transplant is considered or declined, and of course, when people with CF or their family members request palliative care support, that would be a time to think about leveraging specialty palliative care teams or clinicians to support patients and their families. Again, when we think about bringing in another provider, like a palliative care specialist, communication between palliative care and, for example, the CF care team is really, really important so that there's not crosstalk, so that, for example, people living with CF understand why they're being referred to a palliative care specialist, so that they understand that the CF care team will remain the quarterback of their team, and that the palliative care specialist is there to aid the CF care team in optimizing care delivered to that person. The next recommendation that we put forth is specifically regarding the transplant experience. So the CFF recommends specialty palliative care consultation when an individual with CF is considering or declines transplantation. From the literature, we know that palliative care is very infrequently used in CF overall. And when it is used, it is used during the transplant period, but even then it's used really late in the transplant experience. And there are many missed opportunities for palliative support throughout that experience. Some of the potential benefits of involving palliative care specialists during the transplant experience include improving or stabilizing symptom burden in the entire transplant continuum, even post-transplant, addressing unrealistic expectations regarding survival post-transplant, and addressing family conflict regarding goals of care, whether transplant is the best decision for this family unit and that patient, whether there's discrepancies between understanding between care teams and families and individuals with CF. So really bringing in a palliative care specialist to help navigate that experience and optimizing people's experience with the process of transplant. And importantly, when palliative care specialists are involved, the CF care team remains the important linchpin throughout the entire experience. So really not thinking about palliative care as a handoff. Even hospice, when people reach the end of life and we're talking about hospice, we are not recommending that CF care teams hand off people to a hospice service, but rather that they remain involved. Many reasons for that, but really the ones that we want to drive home are that the fact that the CF care team has had the longest experience working with that individual with CF and their families and understands them probably better than anybody else on the care team, but also that CF is a complex illness and that CF care teams will have the expertise in CF as an illness and an expertise about that individual and their lived experience with CF. And they can provide that information to palliative care specialists to, again, help palliative care specialists understand the unique needs of individuals with CF and the unique needs of that specific individual with CF. And then also by starting that relationship, palliative care clinicians can then provide some education to CF care teams, again, in these palliative domains. So really thinking about, again, coordinated care across CF care teams and palliative care specialists, but really thinking about the CF care team as, again, that quarterback that is responsible for and will lead the charge for that individual's care experience throughout the entire disease trajectory, whether we're talking about early palliative care when somebody has a really great prognosis but is needing additional palliative support, or whether we're talking about hospice at the end of life. The CF care team does remain the critical point in all of this. Last but not least, we'll cover some recommendations that we put forth regarding screening and assessment of palliative needs. Of course, a lot of what we talk about in terms of operationalizing palliative care and leveraging various forms of palliative care, whether that's primary or specialty palliative care, require us understanding that an individual with CF standing in front of us has palliative needs. And how do we do that? That requires continuous monitoring and screening of palliative needs throughout their illness experience. So 3 recommendation statements, but I've boiled them down here into this figure. So really what we're thinking about is screening with a tool called the Improved Palliative Outcomes Scale, or the IPOS, which can be found online at MyCFF. The IPOS we recommend being used in individuals years 12 or above annually or at disease milestones. And when we think of disease milestones, we define these in the manuscript that accompanies these guidelines. We're really thinking about a change in disease status, the other concerns coming on board, whether that is thinking about transplant, for example, or whether there's, again, just any change in their disease over time. Thinking about annual screening and PRN screening. For patients who are 12 or below, we think about using the IPOS to guide conversations, not being used itself to screen, but really to use the questions that are on the IPOS as a jumpstart to a conversation with children with CF and their family members about various palliative needs. And for caregivers, we recommend offering on an annual basis the BASC, or the Brief Assessment Scale for Caregivers. Again, these tools are available online to the CF care community, and others in this session today will touch upon these tools as well. So in summary, pulling this all together, so palliative care is relevant throughout the entire CF experience. I don't want folks to leave today thinking about palliative care as end-of-life care necessarily, although palliative care can be leveraged through the form of hospice, for example, at the end of life. But really, we're talking about palliative care walking the course of CF from birth all the way through death and bereavement. CF care teams do have a key role in identifying and offering first-line palliative support as primary or generalist palliative providers, and we recommend doing that through annual and PRN screening with the IPOS. And like I mentioned, a lot of what already happens in CF care can be considered primary or generalist palliative care. And we're thinking about how do we provide extra support to CF teams to beef up their role in providing primary palliative care skills through enhanced training. And last but not least, we should be thinking about palliative care specialists as a backup, as a reserve to be there to jump in and help whenever needs become complex or intractable, when we're thinking about a really important disease milestone like thinking about or declining transplant, and then of course at the end of life, when symptom needs or other existential or psychosocial needs really come to the forefront, and we're thinking about providing comfort and really aggressively approaching quality of life optimization. Like I mentioned, these guidelines were published in 2020 in the Journal of Palliative Medicine. In that manuscript, you'll see all of our recommendation statements, the methodology that we took to develop those recommendations, as well as a number of really important resources to you to help you think about operationalizing these recommendations. As well, on MyCFF, you can find our implementation toolkit, which further speakers today will be talking about that implementation toolkit. So please know that resources are available to you as primary palliative care clinicians in your role as CF care team members, as well as thinking about how do we provide support from palliative care specialists as well. Thank you very much for your time. Have a good day.
I'm Mary Beth Prier, and along with my colleague Elizabeth Dellin, we are going to talk about special considerations in palliative care. So you'll see on the next slide the title of our talk. And so you know, I am a pediatric psychologist and Elizabeth is a pediatric pulmonologist. And together we work at the University of North Carolina, Chapel Hill, Pediatric Cystic Fibrosis Center. So you'll see that we have a few disclosures. We are both supported by CF Center grants, and Elizabeth also has some research support. So to take you through our outline, you'll see first we'll start with kind of a brief review of the definition of palliative care, and we'll talk about how it's different and appropriate for people with cystic fibrosis. Then we'll cover a few special considerations, so starting with how palliative care can be different in pediatrics and for adults with cystic fibrosis. We'll talk about caregiver support, how palliative care can be really helpful when we're considering rapid therapeutic advances, such as modulator treatments, and then thinking about transplant. And then we'll try to put it all together for you to think about some differences and how we can ensure delivery of quality palliative care.
So to review, palliative care focuses on reducing physical and emotional symptoms and improving quality of life for people with CF throughout their lives. Palliative care occurs alongside usual treatments and is individualized according to the unique goals, hopes, and values of each person with CF. The key domains of palliative care are symptom management, communication, emotional support, and care coordination. We are all aware and obviously delighted by the fact that outcomes in CF are improving thanks to therapeutic advances. And these are depicted here in this figure alongside the notable increase in median predicted survival in the red line over time. This timeline, this is an old figure, actually stops even before we get to our newest and most effective CFTR modulator. And of course, lung transplantation, not depicted here, resets the clock for some people with advanced disease, offering longer survival and we hope improved quality of life. All of these advances may leave people wondering how palliative care fits into CF care and whether it's even a necessary part of CF care. So we're going to turn back to the definition of palliative care in order to shed some light on this. I've highlighted some key points in the definition here that palliative care aims to reduce physical and emotional symptoms throughout the lifespan of people with CF, and it's individualized according to the goals, hopes, and values of each person. So if we think about CF, it becomes pretty apparent why palliative care is appropriate for people with this disease. It's a lifelong progressive condition with unpredictable individual outcomes. And while there have been some advances in therapies that are pretty incredible, CF is unfortunately not curable at this time. There are large symptom burdens and treatment burdens, and people with CF face complex decisions, including for high-stakes treatments like lung transplantation. Additionally, there are burdens associated with caregiving and cystic fibrosis. Since people with CF stand to benefit from palliative care, it's important to consider how best to deliver palliative care. And until recently, there haven't been any CF-specific standards. We're currently developing guidelines that address models of palliative care, pain management, and serious illness communication in CF. The guidelines address common perceptions of palliative care, such as things like the needs of people with CF when it comes to palliative care may be different, that the CF care teams actually provide a lot of primary palliative care, things like basic pain management, basic depression management, and hard conversations about things like prognostic uncertainty. Our guidelines also address the fact that more education and support are needed for CF care teams to provide palliative care and to partner with palliative care specialists who can help fill gaps and address unmet needs.
So now we're going to talk to you about some special considerations in palliative care. And I'm going to take you through some of the domains that Elizabeth mentioned as kind of most important in palliative care. So in the next slide, I'm going to start by talking about symptoms and start by talking about the importance of appropriately assessing them so we know how to best treat them. I'll use pain as an example, but we can think about lots of other symptoms as well. So when we think about pain, we have to remember that pain can be very subjective. I sometimes joke, I wish someone else could have my migraine, not really, but to tell me how painful is this for you? Do I have a pain tolerance or not? For kids, that's also hard, right? We don't know what they're experiencing. Sometimes they have trouble with emotion awareness or labeling as well. I have a young one who will say, "Mommy, my stomach hurts." And that may mean I don't want to go to school today, right? Or I'm feeling sad. So we don't always know when kids have somatic complaints what they are talking about. With regards to different scales we can use, around 3 years old, can start using things like FACE's pain rating scale. You'll see here. So we have the 0, no hurt, the smiling face, all the way to it hurts a lot. So around 3, again, we can use this. There are other scales we can use, though, for kids who aren't able to communicate or who may have neurological impairments, things like the Flax Scale. So this is providers assessing what they think or how they think someone is experiencing a symptom. And this looks at things like physical symptoms as well as things like consolability. It's around 6 then when kids are able to start using what we would call numeric scales, right? So a scale of 1 to 10. It's hard to know, though, what is an 8 for you? We talk about 10 being the worst pain ever. We also have to do some education or talking about what's tolerable. Is a 3 feel intolerable for you, or is a 9 something you can still do things like participating in school? So when we ask the question, what is it getting in the way of? That's really important. So we think about the impairment and the big overall effect on someone. We also look a lot to parents to help us with assessment. And my question is, are parents accurate? That's hard to know. It's helpful to ask things like, so when your child is in pain, what do you notice? Or when your kiddo is really nauseous, We have to be careful when we say things though, like they don't look like they're in pain or they're nauseous, right? Because they're eating 5 pieces of pizza, so they can't be nauseous, right? Or they're up talking on the phone. It's really easy, tempting sometimes to say that, but we have to remember to ask the kids because they are the person experiencing the symptom. Another thing to be aware of are symptom clusters. So often we see things going together. So for example, if I'm short of breath, I may get really anxious. And then if I'm anxious, I might also get short of breath. So things come together. We also know in things like diagnosis of depression that there are a lot of physical somatic symptoms. So things like decreased energy or trouble sleeping, changes in appetite. So important we don't think about a symptom by itself, but as a whole kind of assessment. And so again, it's important that we think about that so we think about the right way to treat these different symptoms. So another big area within palliative care is decision-making. So you see my little cartoon here, Boss Baby. We used to assume, or sometimes we'll call kids little adults. Now they may want to act that way or think they can be, however we know that they're not. So really helpful to think about cognitive development for kids and what's appropriate at different ages. So decision-making, we have to think about who's involved. Are we letting a 5-year-old decide what happens? Are we giving the 15-year-old complete power in decision-making? So who is involved, and then what happens if parents and children disagree? So I may say, hey, guess what, kiddo, you're going to school even if you don't want to, and that may seem reasonable, but there may be other times when we're wondering what could be the quote-unquote right decision. So in the next slide, you'll see something we talk a lot about in palliative care, which is called shared decision-making. So we often talk about in medicine this kind of switch from physicians or others in the healthcare field telling people what to do. This is what you should do, and how we've now wanted to swing more towards shared decision-making, talking through decisions with people. This is a big part of palliative care, helping them gather information, think through different things. And we do this a lot too in pediatrics, where we're partnering with kids as well and helping involve them in their decisions. One of the hardest things, though, is when we feel like we have options that don't feel so great. And so you'll see here something that is within ethics, as well as the idea of best interest standard. The idea that when we're making a decision, we want to determine the net benefit for each option, and overall want to choose the option that has the greatest proportion of benefits compared to burdens. Now, what's really hard, again, when palliative care can be helpful, is when you feel like, hey, the benefits aren't guaranteed, but the burdens are. Or let's say you're choosing between 2 things where the benefits and burdens are equal. So how do you make a decision? So there are different tools and, again, conversations teams can have involving kids to think about these things. And I'm not sure if you can see it because our faces may be over it, but I have a picture here. My joke for you is that germs are not for sharing, but let's think about how decisions can be. Then another domain in the next section, on the next slide, I'll talk to you about is communication. So really important when we think, again, about kids' development, and we wonder, who do we talk to, right? Are we telling this 5-year-old, and how are we doing it? Hopefully we're not going in the room and telling children information without their parents there. We're having conversations with parents, perhaps before or outside of the room. And then we have to think about what information are we sharing. Often we may filter information we give to kids. So we could think about, is it important that they know everything, or might we give them some parts of the information? And I think that's different from the idea of keeping secrets. So sometimes parents will want to tell mistruths or partial lies, let's say, and that feels really awful sometimes. Generally, parents have well-meaning intentions, and I think that's helpful to discuss with parents. As I mentioned, cognitive understanding kind of goes along with developmental understanding of illness, so cystic fibrosis, as well as death. So I often think for myself, what do I know for sure about death and dying? I think there are a lot of things I still don't know, and I work in palliative care. So I often will kind of tell learners, let's think about 4 components. The first being that it's universal. So all living things die. It's really hard for little kids, though, to understand that they themselves may die. Generally, we think it's older people. Also that it's final, that it's irreversible, although we may argue, is it really, if we think of things like cardiac arrest, and that there's a cause, meaning biologically there's a cause, although we may wonder about bigger causes, for example, spiritually or existentially. So you'll see, if you go watch this clip, you can watch it on YouTube. Big Bird is supposed to be 6 years old, and he's told that Mr. Hooper has died, but he forgets about it, so to speak, comes back and says, well, when will I see him? And why did this happen? And who's going to take care of me? So kids ask lots of hard questions and may not understand everything at different stages. So that leads me to parents' worries. Often, sometimes they're keeping secrets, so to speak, because they're scared about how their child may cope with difficult information, even a diagnosis of cystic fibrosis. I work with older kids who don't even know that they have that illness. So I often talk to parents about two things, honesty and control. So I want parents to feel like they can be honest with their kids and that we can too. And so I often will say, as providers, we don't want to lie, or we won't lie to your kids. The other thing is control. I want parents in control of when and how their child learns certain information. One of the ways we can help kids then explore their questions and parents prepare for conversations is using tools like the one you see on the right, Voicing My Choices. It's a way for kids to write down things they're wondering about or hoping for, and can be a great conversational tool. And then next, I think I will cover caregivers. So another big part of palliative care. We have to think about, we may typically or automatically think about parents as caregivers, but there are a lot more people caring for patients with CF, and in pediatrics, perhaps more so. So who else is there? Are there other family members, siblings, grandparents, and then also a big community often cares for kids, like schools. So helpful that we're coordinating with all of these people. We also, as palliative care people, think we're only thinking about grief at end of life, but there can be grief along the way, even with a diagnosis. So helping parents process these emotions across lifespan or stages of illness. And then we all know, or maybe not everyone, but parenting is really hard, even without a chronic illness. So thinking about all these additional stressors caregivers are coping with. And then across time, people shifting their caregiving from parents being primary caregivers to then you becoming your own caregiver, and then thinking about new people like spouses, for example, who are partnering in caregiving. On the right, you'll see some things taken from the guidelines on palliative care, and you'll see it talks about ways that palliative care can help. So for example, addressing spiritual and existential distress, exploring grief and bereavement needs, and then screening caregivers using different forms, one of which I'll show you about in just a minute. But the last thing I would say about caregivers is that you all are caregivers as well. We may forget sometimes how big of a role you play for your people with CF. And so it's important you think about your own grief and bereavement, again, as you care for your patients and the long bonds that you form. I think another thing to mention recently that I've heard a lot about is moral distress in caring for patients. So thinking about how much you want them cared for and how hard it's been during this time, or even things like vaccination and how hard that is talking with patients when you feel like certain decisions should be made. So the next screen, as I mentioned, I'm going to show you the BASC. So this is recommended for annual screening, and it's called the Brief Assessment Scale for Caregivers. And I should also mention, while you are screening for anxiety and depression annually for caregivers, this is one of the recommendations from the palliative care guidelines. I think even if you don't or you aren't able to screen for this annually, there's some really great questions on here that you can think about or perhaps integrate into conversations. So you see in the first part, they're asking things about patient or caregivers' emotions. How often are you feeling worried or depressed because of your loved one's illness? And then you also ask questions like, how much distress does it cause you? Or how much distress from making decisions? And then in the last section, I love some of these questions because instead of thinking about negative impact, it's also then asking, well, how much has taking care of your loved one brought you closer or brought you meaning? So I think a really great tool to just remember to perhaps pull questions from if you aren't using it annually. And I think that's my part on caregivers. So Elizabeth, I think I hand it back to you. Yes.
Yeah. So another special consideration that we mentioned earlier is rapid therapeutic advances in CF, leading to better outcomes. You're all familiar with the drug development pipeline that's shown here on the left. And thanks to these new therapies, many people with CF are enjoying benefits like expectation of a longer life, reduction in CF symptoms, and overall improvement in quality of life. But until there's a cure for CF, and even beyond that time for people who are still living with disease manifestations, we anticipate that people with CF will still have palliative care needs. It's very exciting that the vast majority of people are or will soon be eligible for treatment with highly effective modulators. But we're all also very aware that it's not 100%. And unfortunately, not everyone who's eligible for a modulator will derive benefit. Even with modulators, there's still many people living with or facing advanced disease. Some uncertainty and unknowns remain even for those who are clearly deriving great benefit from highly effective modulators. I'm going to refer you to a presentation by our colleagues Lee Landis and Ashley Brown that highlights some of the uncertainty that rides alongside all of that excitement. Things like long-term benefits, what will they be? What about tolerability in terms of physical side effects or mental health effects of modulators? And the impact on one's future and all the potential changes in everything from life expectancy to education and career goals, relationships, parenting, family building, finances, and insurance. And there are worries about those for whom modulators could extend the late stages of lung disease and have complicated effects on eligibility for lung transplant. So let's shift gears for a moment to the topic of transplant, specifically lung transplantation, and how that might affect palliative care in CF. We're going to do the same exercise now that we did earlier by going back to the definition of palliative care and then thinking about how it fits into transplant. So like CF, transplant is itself lifelong or at rest of life, at least, and it may have a phase of illness progression. Individual outcomes are unpredictable, and we of course know that it's not a cure for cystic fibrosis. Transplant comes with symptom and treatment burdens, and also complex decision-making, sometimes even about redo lung transplantation. Caregivers also bear burdens in this phase of CF care. This figure is a really simple depiction of how palliative care comes alongside usual care for people with CF or any condition from diagnosis through end of life. So with transplant in the mix, it almost starts over, and that transitional phase is often very difficult for everybody involved. To help address the ever-changing and often intense palliative care needs around this time, the CF Foundation recommends specialty palliative care consultation when an individual with CF is considering transplantation or when someone meets criteria medically for transplant referral but declines it. This can be a challenging time in many regards and a time when people can easily become confused about goals and hopes. There are a lot of myths and misperceptions about palliative care that really need to be addressed in order to maximize the benefits of specialty palliative care consultation. And I'm just going to give you a few examples. So first, there's a perception that palliative care is only for people who are at the very end of life. And the reality is that it's not just for end of life. We've talked about that. But also those who are sick enough to need a transplant may actually be an end of life. They may not survive to receive that transplant. There's also a perception that transplant and palliative care are mutually exclusive, but actually it's possible and often beneficial to have both. In fact, there's a specific recommendation from the CF Foundation around this. Palliative care takes away hope is another perception that people have, but in reality, those of us who practice palliative care know that palliative care is all about hope. It's important to remember that hope is not a monolithic entity. People who are living with serious illness can certainly tell us that they can be hopeful for many things. And finally, there's a perception that opioids are the mainstay of symptom management and that they can't be used safely in CF or transplant. This is a complicated issue, but the reality is that opioid medications are one of many tools that could be used to treat distressing symptoms like pain and dyspnea. And when they're indicated, they can be used safely with careful prescribing and monitoring the vast majority of the time. But this is, again, a really complicated topic for another talk entirely. So let's just bring this all together briefly to think about the unique needs of people with cystic fibrosis when it comes to palliative care. So as a reminder, the CF Foundation recommends that CF care teams deliver primary palliative care as a part of usual CF care at the time of diagnosis and throughout the disease course. And this approach is depicted here kind of as succinctly as possible as in something that is so individualized and complex. But the chaos of this picture reminds us that we need to take into account all the unique things about CF that might make palliative care delivery a little bit different. So caring for people across the lifespan from birth through childhood and through adulthood, considering the roles and needs of caregivers along the way, providing palliative care along the spectrum of disease severity, and shifting gears a bit when this is affected by highly effective modulators or other novel therapies. And of course, considering the intersection of advanced disease, lung transplant, and palliative care.
So we'll just remind you of or recommend that if you haven't already, you read this consensus guidelines on models of palliative care for individuals with cystic fibrosis. There are several kind of recommendations within here. The first being what is primary palliative care in cystic fibrosis. The second being when you would want to consider specialty palliative care consultation. And the last being some screening and assessment tools for palliative care needs, including the BASC that I mentioned earlier. Next slide. And here are some resources for you to look for in the CFF resource library. So there's a PDF with guidelines, and then there's a palliative care toolkit to help you start this at your center, and then a great webinar to watch with more information. So we thank you so much for listening to us today and learning more, or we hope, and please feel free to reach out to us with any questions. Thank you.
Hi, everyone. I'm happy to be here today to talk about a recent study I conducted on the experience of pain in cystic fibrosis, a narrative study. I have no disclosures related to the presentation, and just a few objectives to start with. I'm going to briefly summarize the current evidence base for pain in CF, describe the study design and narrative methodology I used in this study, and then explore findings through some structural narrative analysis. For background here, and really a mini background, within the literature review for CF, it was deemed or found that pain is an important issue in CF. That was clear. And pain in CF may affect quality of life, mental health, and adherence to treatment. One thing that was noticeable is both pain and CF are individually recognized as complex phenomena, yet evidence on pain and CF is almost exclusively quantitative. We see this in looking at the included studies. There were 14 studies, and 13 of these primarily consisted of pain assessment tools or surveys. The other one of those was a retrospective chart review. And importantly, only one of them even sought the perspective of the person with CF. So we have this knowledge gap about pain from the perspective of the person with CF. So my study aim was to explore this complex experience of pain and CF from the perspective of those living with. Easy enough, right? All right, so I chose narrative methodology for my approach here. I don't have time to go into all of the details. I think narrative is just a lovely methodology, and I highly recommend it, but we'll just cover some basics here today. And that is, I focused on the whole person, which I think is essential in the study of pain. So that was one, very important part from my perspective to make sure that we did. Of course, narrative is one of the qualitative approaches, so that deepens understanding of complex experience. Narrative in particular aims to explore unique experience and how people tell stories of their experiences, and also the relationship with both the experience and those stories over time. So it's really looking at the construction and meaning of stories. It's more than just studying the narratives themselves. I take an approach that is looking at not just, a qualitative or thematic approach to the narrative, but really using a narrative methodology for the analysis itself. So a little bit more in depth than just a simple qualitative review of a narrative. It has been said by more than just these three, but multiple researchers, that narrative is the ideal approach to the study of pain. So before we get started on the actual findings, I did want to talk some about total pain theory. So when we look at total pain theory here, we're looking at a model from Dr. Cicely Saunders. This model's been around for quite a long time. You may have seen something quite similar, the biopsychosocial model of pain. I very purposely choose this model. And the reason is that there's an emphasis here on the whole person, and there's an emphasis on the relatedness between the different domains of pain. So in this model, we have the domains social pain, psychological pain, spiritual pain, and physical pain. And where these different domains of pain intersect, they intersect in an area of total pain. And so there's really a whole personness about this approach. And it looks at the relationship of all of these domains within and between each other. So that's one key reason why I chose this as a lens to look at my study findings here. So when we look at the summary of key findings, the findings show that participants view the experience of pain in CF as more than just physical pain. That became really clear from moment one. Emotional pain, or what they deem emotional pain, is really dominating their narratives. So if we use the lens of total pain to help guide interpretations, I saw all domains of total pain present within the narratives. Participants importantly also spoke of suffering, and this will become important later on. So after considering this discussion of suffering and in relation to total pain theory and affecting the whole person, then really my evolution throughout the study really resulted in my understanding of total pain and suffering as a singular experience. So not something to be carved out and looked at separately, but really a singular whole experience. The study argues that total pain in the context of living with CF threatens social legitimacy. So we'll talk more about that soon. Eventually, when pain and suffering persist, participants can lose social legitimacy and subsequently feel invisible. And this ends up being a significant cause of really deep pain there. So these findings overall highlight the importance of studying the experience of pain in the context of the whole person living with illness, rather than trying to carve it out. What I'm going to go through now is there were three main narratives that emerged, and that's along which all of these findings came forth. So the first is emerging awareness, and then social legitimacy and invisibility. So first, just a couple highlights on emerging awareness. These stories were really followed a chronological order. And but for narrative purposes, for narrative research, the way that it works is participants really direct their own story. So it's much less structured in terms of interviews than other research methods. But all of them, every single participant, did tell stories in a chronological order. That's not surprising. We as human beings do tend to tell stories in a chronological order. They shared their stories along a narrative of emerging awareness, where across their lives, they gradually became increasingly aware of what having CF meant. And the findings suggested that participants were really living in a liminal space, a space of always being in between. So being between being sick and not sick, living and not living. So there was a definite liminal quality here. Total pain was present in various forms across the entire spectrum here, but emotional pain really dominated these narratives of diagnosis and early disease. Whereas as that progressed, social pain became even more evident as CF illness itself progressed. And then in the advanced stages of illness, we really saw more of a spiritual or existential pain being shown there. One thing that is notable here, and we can't go into it in a lot of detail, is that the fear and uncertainty found within the liminal space really seemed to create quite a bit of distress for participants. So here's one example of one of our narratives. And when I said structural analysis, what I mean is taking a interview transcript And then I'm looking at discourse analysis, and this is where the narrative really comes in. So I'm looking at patterns of speech. I'm looking at where are the pauses, where are the ums or ahs, where is there great emotion shown. Sometimes I'm looking at intonation or pitch or inflection within the voice and speech patterns. And by doing that, I can then determine how to break a full interview transcript into, or how to convert that into a stanza, which is this poetry-like form. And what I find is that breaking the interview transcript into these stanzas really creates the essence of the experience. So in this case, this is Samantha, who talks about, emotionally, it was really rough as she learned what having CF meant. There was a crescendo effect of increasing total pain and suffering occurring along this emerging awareness. And this crescendo effect really became part of an overarching sense of movement or fluidity and continual change going on along this emerging awareness narrative. So the next example I have is Brittany, who's talking about it being harder and harder for her to stay healthy. And so in these emerging awareness narratives, the experience with CF for each individual was changing as they became sicker, and then as they were changing in relation to it. So this was, at least in part, I think, because, construction of an illness experience itself is considered socially constructed. So we expect as people grow that they would change a bit in relation to this. These changes also created this sense of movement or progression along a narrative. So you have this sense of passage of time here. Next, we have Christopher, and this is perhaps one of my favorite metaphors in the narratives. And this is an example of where metaphor is really strengthening the narrative. And regardless of whether you yourself have CF, you get a sense of this slow and insidious progression. So we look at Christopher, who says, I would consider almost everything I've experienced with cystic fibrosis. It's very slow, repetitive. Kind of like how a drop of water on your forehead isn't uncomfortable until the 100th drop that lands on your forehead. And he goes on in his very next stanza, which I don't have up here, but he goes on to talk about the constant beat down. So you can see where the visual representation really makes a difference here. And now we move on to another stanza, another excerpt from an interview from Amanda. And in this, we're really demonstrating in the emerging awareness narrative a shift from a linear sense of time where you've got past, present, future, to more of a pendulum experience of time. And this is described pretty frequently in the chronic illness literature. This is where participants are kind of simultaneously living in the memory of their past by remembering a time they felt healthier, or even remembering trauma or pain, while at the same time they're coping with their present, and then they're anticipating future events and uncertainty. So this was this key feature in stories, and this is where we really see the depth of that liminality, where we have this experience of living in between. And these liminality and these milestones really seem to be closely related to uncertainty and fear and expressions of both emotional but also spiritual pain in the narratives. So now we're going to move on, and there's so many examples of each of these that I've really picked just a few highlights because we have a short period of time. But now we're going to talk a little bit about social legitimacy. And in this case, you've got this lifetime emerging awareness of what it means to have CF, but nowhere in the narratives did anything have a deeper impact aside from when participants felt that they had no social legitimacy as people. This was one of those, really an unexpected finding, not something I expected to find in here, but a really striking finding occurring across all participants here. So these are participants striving for social legitimacy, pretending not to be sick, really trying to be normal and independent, which we've all seen. And at times, the striving for social legitimacy can be beneficial. but it can also be physically exhausting and unsustainable at a certain point. And when people aren't able to keep that up, then there can really be a loss of a sense of identity and self-worth, and thus, some social pain really experiencing with that. And so as participants were moving away from this healthy role and towards the sick role, they were experiencing numerous losses from social role, identity, lack of independence, to even hopes about a life previously known and hoped for. And as these losses began to stack up, they really contributed to the total pain and suffering experience that came forth through their narratives. So here's an example here, and this is Brittany talking about having to stay at her parents' home and moving back in. And she said, having to stay at my parents' house for so long, not hard because I love them and they're like totally okay with me staying there, but like just as a personal goal and feeling successful or feeling like I'm an adult. So this is where we start to have a peak of social legitimacy in these narratives. And this is where, you're really seeing it as a response to illness and a coping mechanism. But all participants had this in there as they sought independence. And then here we turn back to Christopher and another part of his overall narrative here. And this is where he's talking about being with his wife and feeling like he's being perceived as feeble. And in his words, he says, you just don't feel like Superman anymore. And then he goes on to say, yeah, that's kind of the Superman. Like nothing can stop me. When you feel like you're the man, you're the one that stands up for the protector and all that stuff. So striving for social legitimacy here is really described well in the literature on sociocultural conditioning. So in Western society, we have this strong value we place on hard work, on productivity, on accomplishment, financial success, independence, etc. And this perception of social legitimacy can just be really difficult to reconcile with an illness like CF, where, of course, those around you and even yourself may understand CF as life-threatening and progressive and unpredictable. But sometimes society still reinforces the expectations of hard work and productivity. And even if society doesn't do it, sometimes we, the participants, put that on themselves so that it become very clear. So here's one more example. I would bet all of you have heard something similar to this before. And this is a young woman, Ashley, who describes that she says, I think everyone with CF has to push on. Otherwise, what is the point? There would be nothing to live for. We've been doing it all our lives. It's all we know. And here again is Western society's high value placed on this model of pushing through illness. And this includes our healthcare systems. When we applaud someone who's, we elevate them to hero status when they're very sick, and yet they're rising above and all of the things they're still accomplishing. And like I said, sometimes that's beneficial, that's great. But there was a lot of pain that came through these narratives in response to that, more so than I would have expected. So it's just so ingrained in how we respond to illness. So finally, this is the narrative of invisibility. And this was one that, definitely took some unpacking. And I think, the nature of something being invisible is that it's invisible, so it can be a little harder to tease apart. But nowhere was total pain and the impact of living with CF more obvious than when participants felt invisible. It was huge, and it was kind of, I would describe it like an iceberg, where participants revealed in their stories that there was so much more going on under the surface than known even to people who were really close to them. So this recognition of the loss of social legitimacy related to total pain and suffering, and then eventually resulting in participants feeling invisible, really became one of the keys to understanding the holistic experience of pain and CF. So it was really within these stories of invisibility that the true depth of suffering started to come through. So let's look at a couple here. And this may be familiar to some of you as well, but this is Michael, who really is saying the hard part of people understanding the pain with CF stuff. And Michael had a lot of physical pain. He goes on to say, because they think CF think with CF, they think lungs. They don't think the other stuff. So they don't look at anything else other than CF from Michael's perspective. And this was something that was heard again and again and again, where participants said lungs and gut. That's all the clinicians care about, lungs and gut. And what a lot of participants were doing is they weren't reporting anything that wasn't lungs and gut, because we had conditioned them to that's all we cared about. And when I say we, I say that very collectively, knowing it's not the case for all. But because of this, because it's so much focus on these on these other aspects with lungs and gut, pain and suffering oftentimes was invisible. And in fact, here's another instance of invisibility where Michael's talking about growing up. He used to have no problem telling people about what's going on, but I'm tired of doing this all the time. The CF, the pain, everything. I had no problem talking about it because it didn't bother me as much as it does now. Now it drains me a little bit here and there. Drains me a little bit here. And then the pain and everything, I'm just tired of talking about it. And so this is just another reminder of, Michael was saying, he just doesn't talk about it. He has tons of pain, but he doesn't tell anybody, simply because if he talks about it, it's a reminder of the bigger picture for him. So lots of spiritual pain seen there. And then this is Amanda, where in the interest of time, I won't read her narrative, but she's talking about losing friends because CF is not always a visible illness. And her friends say, well, you looked fine yesterday. So she's lost friendships over it. So I want to close out with talking a little bit about suffering. And I would implore you to not read the slide while I'm saying this, but I know it's always so hard to do. But some of you may be aware, or you may not, that there's some controversy around the use of the word suffering. So in this study, I embraced total pain and suffering as a single experience. And I did not shy away from using the word suffering, even though there were lots of discussion in my past about the controversy around this. But this was the language that participants used. And there's something about honoring the language that they use. And in this case, the word suffering used by Brittany really is a powerful word. So she says here, someone asked me, a dorky guy at work asked me, he was like, how do you feel about, how does CF make you feel? And I was like, okay, do you really want to know? Really want to know? I could go there. Do you really want to know? And he was like, yeah, tell me. And I was like, it's just a lot of suffering. It's all just suffering. I can't explain it any other way. And if you heard her tape, she trailed off in her last 4 lines there to almost a whisper at the end. So very powerful indication of what suffering is meaning to her. So there's several implications for clinical practice. I'm really only going to focus on one, and that is that listening to the stories people tell and acknowledging and honoring their meaning and acting on these stories, it's really the hallmark of narrative medicine. And so, really relevant to our findings here is Sharon, really one of the founders of narrative medicine, really felt that narrative medicine clinicians are able to see suffering and total pain. So she felt like narrative medicine was really almost a window that you could open in which to see. So a closer look at narrative medicine may provide interested clinicians some support. This is really a shift in how do you view healthcare. And so accepting this broader view of healthcare really does mean you're accepting a role in addressing total, pain and suffering as a whole person. So with much of the focus on healthcare and fixing, it may be a little difficult to appreciate the value in simply listening to someone, but I would encourage you to do it, and end with a quote by Cicely Saunders, who described this as the way care is given can reach the most hidden places. Thank you very much.
All right, well, welcome everyone to this presentation in this part of the symposium. Let me share my screen. So this is going to be a presentation within the symposium titled The Spectrum of Palliative Care, Providing a Lifetime of Care and Support. This presentation is titled The Value of Longitudinal Palliative Care, the Patient Perspective. We have a lineup of excellent speakers, Noor El-Shar, Amit Euler, Nicholas Pearl, and then I'm one of the moderators for the symposium. Of note, none of us have any relevant disclosures related to this presentation. So with that, I'm actually just going to turn it over to have everybody introduce themselves. Again, I'm Elliot Rabinowitz. I'm a pediatric pulmonologist as well as pediatric palliative care physician here at Boston Children's / Dana-Farber Cancer Institute. Nick, I wonder if you might be able to introduce yourself.
Hello, everyone. My name is Nick Pearl. I'm a social worker at Boston Children's Hospital and Dana-Farber Cancer Institute on the palliative care team, or the PACT team here. I also help to serve as our fellowship director for our social work fellowship program.
Thank you. Amit?
Hi, everybody, and Elliot and the CF Foundation, thank you for the invitation to be able to be here today with this amazing group. I'm MedPed, so medicine pediatric trained pulmonologist and the director of the adult CF program here at the combined Brigham and Women's and Boston Children's Hospital CF Center. I'm also the director of a program called the Bridges Adult Transition Program, where we care for adult survivors of congenital and pediatric acquired diseases. So with that, I have a perspective of both the palliative care team at Boston Children's Hospital and Brigham and Women's, and look forward to our discussion today.
Thank you. Noor?
Hello, everyone. I am Noor El-Shar, and I'm honored to be here with all of you. Thank you for the invitation and for having me be a part of this great symposium. I am an adult with cystic fibrosis, and I'm 2 years and 8 months post bilateral lung transplant.
Thank you all. Well, to really kick off this discussion, Noor, I'm going to look to you to first sort of get us going here. And I wonder if you might first start by just sharing sort of how you were first introduced to palliative care, to PACT, and just start to share a little bit of your experiences.
Back in 2013, I was inpatient for a clean out before I was hoping to go on a family trip, and just 11 days before our trip, I had a severe episode of hemoptysis and a decline in my health. So the tables were turned, and my health was just not doing so great. So my pulmonary team had the PACT team come in and do a consultation, and they spent about 2.5 hours with me. I really did not know what palliative care was at the time, and I just knew that this was a patient advanced care team, and was hoping that they would be able to just help me through that time and feel a little bit more comfortable than I was, and try to get through those hardships so then I could look forward to going on a trip maybe later on when things were healthier. While working with the PACT team, I developed a great relationship with them and learned that one of the biggest and most helpful pieces of any takeaway I could, or a way to describe them, would be with one word, and that word is time. And time just meant so many different things. And I never once felt that the palliative care team was about end of life or comfort care strategizing. If anything, they were the team that were passionate about doing anything and everything they could to add time to our lives rather than take it away comfortably. Thank you.
Thank you, Noor. I was just going to jump in. Now, I have the extreme privilege of caring for Noor as her pulmonologist and as her primary pulmonologist prior to her getting a lung transplant. And I did my training here at Boston Children's and the Brigham, and I was introduced very early and worked very closely with the palliative care team right off the bat. But I also thought that I could do it all. And because I felt that I was empathic enough and would able to address the needs of the people I care for, I didn't actually think to get palliative care team involved with Noor earlier. We all have a constraint on time that Noor brought up. And even though we'd like to all help our patients feel like we have all the time in the world for them, we're still limited to 20, 30-minute clinic sessions and rounds that can have a fast pace. But it was still a little bit late in the game that we got the palliative care team involved for you, Noor. And that's, I think, one of the things that, we want to discuss, because the time that they were able to spend with you really opened my eyes to a lot or the different aspects of your life that I didn't know about, that perhaps, we just didn't have time to discuss. And so the palliative care team really opened my eyes, and, that lesson has continued with me in getting the palliative care team involved much earlier. I don't know, Nick, if you can expand on that.
So that you both bring up this really wonderful idea of time, and it's kind of different meanings in this context. And I think I really appreciate what you're saying, Dr. Euler, about there's often this idea that as compassionate, caring clinicians, we should be able to do everything. Like, we should be able to take care of all the aspects of care for our patients, and yet, and the way healthcare works, and the way that the number of patients that we care for, the people that we care for, is intensely and deeply that we care for, there's always this challenge of what it means to find the space and the availability and the opportunity to really focus in on these really specific aspects of care. And so I think just demystifying a little bit about what it means when we're talking about a PACT consult, when it means to do palliative care, so to speak, in this context, it's really allowing a little bit of space, allowing a little bit of time, whatever that looks like, to the patient, wherever they are, to help support this idea and cultivate an understanding of their own understanding of what they're facing, of their own illness, and to help really identify and really pick apart these ideas about what's most worrisome about those aspects of their illness and what we're hoping for over time, and how to help to change and support that. And really, that does take a lot of space and opportunity, because I don't think these are things that we're actually naturally asked as people about what we're facing in those instances. And I think that piece of it is really helps us to facilitate a longitudinal relationship with patients, but also helps to facilitate their direct and immediate concerns, to help relay that and support that back with the primary team. So it's a huge part of what my role is really often introducing us as an added layer of support that doesn't take away from the other members of your team, but helps to support and enhance that relationship. And if I'm doing my work well, if I'm doing my job well, then the idea is ultimately to bring that back and work with the primary teams that we're caring for, and really enhancing that relationship between the patients that they know so well and that they care for so well. And I think just thinking about what you were talking about a little bit, Nora, about this idea of time, not to put you too much on the spot, but this idea that I remember many conversations when we were thinking a lot, and you would bring up something that you hadn't thought of before. And I'd say, I think it's really important that we talk about this with Dr. Euler. This seems like a question that he needs to help us answer. And I don't know if there were kind of, as you remember these conversations, times in which you kind of remembered the PACT team relaying this idea of this connection back to the people who are important to you on your care team.
I remember there were a lot of times where I brought up the conversation of transplants, and if that was something that I necessarily saw as part of my future, or it was something I was still thinking about, and why I would want to do it versus why I would not. And I remember I was still very indecisive and not really sure whether this was something for me. And I was very grateful to be able to have that time with you as my social worker from the PAC team, to be able to just sit and talk about it in more depth and strategize maybe why my thoughts went one way versus another. And then that made it helpful in a way that then you could take back those very, like, the most important points and share them with Dr. Euler, which then brought Dr. Euler back to me. And we then had our sit down conversation of what transplant really meant and what it was going to entail, and if it was truly what I wanted to move forward with or not.
Yeah. I think our conversations about transplant were good ones, but they were constrained. And I think that in your, you've spoken about maybe not being as good an advocate to yourself as you were back then, as you are now. And the palliative care team allowed you to find that voice and for us to really explore the idea of transplant and everything else that went with it more deeply, and really that they facilitated that conversation.
Right. And I'm very thankful for that opportunity, because I was able to understand from you all of the true aspects of what it meant, and then go back and break it down and come to the realization of making that final decision that I was going to move forward, and this was something I was going to do. Granted, I did not know when it was going to happen or when it was going to be the right time. And unfortunately, my health declined very quickly years later. And I had to do a very quick transition to just try to get everything done that we could so that I could be stable enough to be listed for transplant.
My understanding of palliative care, was founded in the fact that at Children's, the PAC team, as it's called, really, they adopted that how we understand palliative care today, or how we'd like to understand it, very early on. And I knew that it was about, mitigating suffering, but also, emotional and physically, but also to improve quality of life and us to achieve your goals. And so, and having trained at both institutions, I wonder if you can talk to us a little bit about, as you transitioned your care from the palliative care team at Children's to the palliative care team at the Brigham. Again, this was a while ago. How you saw the role of the palliative care team yourself, like maybe your misconceptions, and then how, that was maybe founded when you went to the Brigham early on, though this was a while ago and things have changed.
In my experience in the children's hospital setting, the PAC team had a very different a call to action versus when I had transitioned over to the adult hospital setting. Granted, again, like I said, I was in a time of crisis and we were racing against the clock. I wish that I had similar experiences, especially having to truly experience those most challenging days of my life, whether it was trying during the days that I was trying to become stable enough to be listed for transplant, or during the time post-transplant, including the first year post, where I just faced a lot of complications. Thankfully, I am so grateful that I had put together and built a toolbox with my PAC team over at Children's Hospital, and I was able to always refer back to that toolbox, especially with my pain management tools during the time I had been over at the adult hospital setting post-transplant.
It really is so beautiful how you talked about that framework of, I think we had a real privilege at Boston Children's for knowing you for so long, to get to know you in different contexts and phases of your illness and how things change. And you alluded to this a little bit, is that sometimes too, with new information or how things change, goals change over time, as does the calls of action. And so what I hear there, and the teams are continuing to evolve and to change, is the importance of being able to think about some of those things in advance that may arise over time, and what kind of tools will be helpful to you. And then also thinking about how important, going back to what we started with, this idea of building that relationship in the context of having that opportunity, that privilege, to be able to get to know you outside of a collection of challenges. And I think that that's an incredibly important experience that may also impact when people transition, and something we should all be thinking about.
Right. My dream is that with time, I would love to have this become more universal and available at all CF centers to better help those with CF manage their care, like you said, before times of crises or times of hardship, whether they are inpatient or outpatient, and most importantly, during the times that they have to navigate those life-changing journeys.
I would just add that, this was 10 years ago now, when you first met the Palliative Care team, I believe.
Right.
And since then, Palliative Care has also evolved at the Brigham. And I'd love to hear Nick's thoughts on the evolution of palliative care, but we do get the Palliative Care team involved early, and to help with symptom management, and to really, sometimes I just feel like the Palliative Care team comes in with like magic, and like sort of magical way with their knowledge, but also their language, and really makes my job so much easier. I know I can't do it all, and I'm just so grateful for those skills that even if we hear it in a lecture, we just don't implement it as well as the Palliative Care team can. Nick, I don't know if how you see that evolving, or Elliot, yeah.
Well, I'm going to let you sort of round this out in sort of some final comments. We have about a minute or two left. And so I want each of you to have sort of a moment to sort of share any final thoughts that you might have for the people listening in and sort of being a part of this symposium. So Nick, I'll turn it over to you first, and then go to Amit and Noor.
Sure. Well, I have to say it warmed my little palliative care heart to hear that this experience of working with this team, and my wonderful privilege in working with Noor and being able to work with the pulmonary team here at Boston Children's. It's just this idea that I really, really do mean it when I feel that our goal is from the patient end to help enhance that experience of celebrating what your life means to you in those moments, both in hard times and especially in the good times. So it's wonderful to see you and to still be able to engage with you in this way, Noor, and I'm so excited to celebrate that. And then for I agree that another part of how we work with the team is that parallel process of making sure that we're trying to enhance and support that relationship as well, and help it connect to bring those pieces together. And so I'm just so happy to hear this is a wonderful experience that we're talking about. Thank you all so much for having me here.
And I would just say, I feel like I kind of gave my closing thoughts there just a moment ago, but I do. I'm just grateful for the Palliative Care team who has enhanced the way I practice medicine, the way I relate to my patients, and knowing Noor the way I know her now is just an incredible gift to me. And I'm going to cede the rest of my time to Noor so we can hear from her.
I just want to share that if you are able to make a difference in anyone's life, whether it be doing a session of Reiki to bring them comfort during a true hard time, or you are able to celebrate, like Nick said, and make bigger dreams come true, like being able to travel and visit family back home, or if it's just simply bringing a smile to that patient's face during that day by just giving them those few extra minutes that they may have needed and being gentle with them. All of it matters, all of it. And I can't stress that enough. I'm so grateful for the palliative care team. Thank you.
Thank you all so much. I certainly look forward to the discussion part of this, and really just so many just excellent insights and values of learning sort of from your experience, Noor, as well as sort of the role that you have played, Nick and Amit. So thank you all.
Thank you.
Thank you.
Thank you.
Thank you.
All right. Well, thank you so much. Again, I'm Elliot Rabinowitz. I'm one of the moderators of this session with Jessica. I first just want to start by really thanking all of our speakers who came and participated in this. I really want to thank everybody who's attending this. We hope that this was valuable and informative to sort of increase your awareness of what palliative care is and how that looks in CF care. Wanted to discuss sort of the 2020 Models of Palliative Care guidelines that came out, as well as really think about how both primary and palliative care and specialty palliative care may have roles in your routine practice. And so hope you leave today with some new insights, new experiences, new knowledge that you can sort of take back with you. Thank you for keeping the chat lively and robust. We hope to get to as many of those questions as possible. So please continue to put questions in there. Feel free to upvote those. And we're just going to get started for this last sort of half an hour or so. So going to start with some of the most sort of common question first, which I may look to you, Elizabeth. And so I'll read it out loud. So wondering if you can comment on how to approach symptom management of CF patients on hospice in regards to specifically sort of airway clearance therapies, and some patients preferring to do airway clearance to reduce pain and mucus plugging, but maybe some misunderstanding from hospice as viewing it as sort of life-saving or prolonging and recommending against it.
Sure, happy to address that. And I want to sort of qualify my response by saying that I am not a hospice physician per se. I don't work for a hospice agency. I don't do home hospice care, but I'm on the receiving end of a lot of communication and calls about hospice as both a pulmonologist and a palliative care physician. I think a lot of this really can be addressed through support and education, and there are actually two separate guidelines, statements from the Models of Palliative Care guidelines that I think address this pretty nicely, and maybe we can use with our teams as ways to partner effectively with hospice and support our patients' care needs. So the first is that the CF Foundation recommends that CF care teams partner with specialists who are consulted to assist with palliative needs to facilitate the specialist understanding of CF care and the unique needs of individuals with CF. So really speaking to kind of supporting, providing information about those unique needs whenever consultation occurs. The other, and then I'll kind of try to bring it together, is that the CF Foundation recommends that CF care teams, and if applicable, transplant teams, take a collaborative approach in offering comprehensive, timely, and compassionate end-of-life care, including hospice, and to provide clinical expertise and support through the end of life. So really, I think, CF is not a common disease, and it's not a common reason for hospice referral. So many hospice agencies may just not have a lot of experience caring for people with CF. near end of life. And so thinking about which therapies are really are intended to provide comfort is really critical. And we as CF clinicians can provide that information alongside our patients and families who are, of course, advocating for themselves. I think when we think about mucus or airway clearance, certainly it can provide comfort just, logistically, physically. It's a part of care that is intended to relieve symptoms. Also, just from the emotional standpoint, kind of maintaining some normal routines at that stage of one's life can be really helpful. And it's another way to interact meaningfully with loved ones in the home and with caregivers. So I think working individually with people with CF to determine whether airway clearance therapies are beneficial in any way in helping support them in advocating along with hospice providers to allow that to continue would be what we would recommend.
Yeah, thank you. I think that highlights really the collaborative nature of this, that the communication has to go both ways between the CF care team and whether it's the hospice agency or palliative care specialty clinicians. All right, this next question could probably go to almost anybody on this panel would probably have something to say about this, but I'll look maybe first to Amit and Noor about, does involving palliative care have a negative impact on patients being considered for transplant or even disqualify patients for transplant?
Maybe I'll jump in first, and then I just want to make sure we hear from Noor on this. But Elizabeth and Dio already mentioned, and Mary Beth, that getting palliative care involved, especially on transplant, is a recommendation. But I think it is a must, and especially as we're managing suffering and pain, we need the voice from the palliative care team to really help communicate to the transplant team, some of these issues that they may be concerned about. There is in our institution concern for chronic opioid use, for example, and its contraindication in transplant evaluation, which is something we push back against and advocate on behalf of our patients to make sure that their pain and their quality of life is being addressed as they're waiting for transplant. We've had a number of patients who really continue post-transplant 10 years later, still remember the pain that they went through in order to meet some of the criteria. And thus, that experience leads us to really want to advocate for patients and pain management and to reduce the suffering as they're waiting for transplants evaluation, since you shouldn't be suffering, to be transplanted. And I think that our palliative care team colleagues absolutely have been helping with that dialogue.
I think that having the palliative care team be a part of my care, and hopefully as part of many other patients with CF's care, was the most impactful part of my transplant process. Not diminishing my CF care team at all, but it was just so helpful to have them be a part of it, because I was having chronic pain, and one of the things that I needed to do in order to be listed for transplant was to stop using any kind of opioid in order to be put on the transplant list. And thankfully, the palliative care team was able to help me reach that and get there by creating, like I said, my toolbox, and as well as advocating for times that we did need maybe a little bit or a very small dose of use of the opioid so that I could continue moving forward. For example, in regards to having to not stay sedentary and continue to be active in order for me to be able to take better rests and not be experiencing too much chest pain. And those were the times that I just needed a little bit to just take the edge off so that I could keep moving forward, so that I would be able to reach my end goal.
And I would just add that the palliative care team has helped change, some of that approach from the transplant team as well.
Yeah, so I'm so thankful to having them, and I don't think that at all the palliative care team would be a disqualification for someone to move forward with transplant. It would be the complete opposite.
Could I just add a comment about the opioid piece of this? And of course, Noor, your experiences are very meaningful for us to hear about. And Jessica, of course, spoke very beautifully and eloquently through or sharing the voices of people who've experienced pain. This is always such a tricky issue. It's something that gets discussed in lots of ways, and different centers have different approaches. Different transplant teams have very different feelings, practices, biases. I just would refer everybody to the Advanced Lung Disease Guidelines. This question was something that was addressed by a committee with multiple stakeholders, multiple medical professionals and individuals living with CF. And there's really no evidence that opioids can't be used safely for proper indications. But this would be a reason that we would think about consulting people with expertise in opioid management, like palliative care specialists or pain specialists, if we think that there's an indication and we'd like to work, partner carefully with the people who are experiencing those symptoms to allow a safe management plan with careful initiation and titration and a deprescribing plan too, right? When symptoms improve. Perhaps if we had better pain management, people would be better candidates for transplant because they'd be more comfortable and able to participate in rehab. I think there are just a lot of considerations. So something that really warrants more attention in many ways.
I think that's absolutely right. And I think it's finding those people at your local places of work and sort of trying to open those lines of communication to sort of understand what their practices are, what their understandings are, maybe what their misunderstandings are, and trying to sort of further that dialogue. One of the questions that has sort of moved up in the chat is a question around wondering if we could speak to sort of this idea of guilt around that patients may experience for not pursuing transplant. Nick, I wonder if you might be able to sort of start us off with that, and then either Mary Beth or Noor, anybody else can chime in. Nick, I think you're muted.
Sorry about that. I think we'd all be used to that by now. Yeah, I think a little bit about this idea of both perhaps guilt, but also this concept of decisional regret in general about different priorities and choices and decision-making that really evolves over time with the patients that we care for. And I think it's important to recognize the universality of the experience of always wondering about the path not taken and thinking about what that looks like for an individual person in a situation like that. And the argument for a good continuity and longitudinal involvement of teams who are able to help think about those decisions in advance and thinking about those decisions and how they came about and what the goals and priorities were in that moment allows us to help sit with patients and think really carefully about how we got to where we were and the kind of really good thinking that went into good, thoughtful, advanced thinking that went into the kind of decisions that we have jointly thought about together. That we're there to really help balance the prioritization of what was important at the time and helping to remind patients that we make the best decisions that we can with the information that we have on the table. And that's not always pure clinical data. That's often about the decisions and what went into them at the time as well. And I think it's a really complicated topic, but it comes up in every domain of the care that we help to provide. And there's equal, I would say, consideration patients I've worked with in the longitudinal course about thoughts about decisional regret for pursuing transplant and how to help also think about those decisions as well.
I would quickly add that guilt's a really hard emotion, right? It's not a friend of mine, right? And you talked a lot about this regret and how you carry that with you. And I think, working in pediatrics, I don't see it as much, but it really is, we assume when we ask people what their goals are that we know the answer. And so really important we explore that with them as we think then, is the decision about transplant in line with your goals and your hopes, right? And also exploring with people their worries. It's hard in pediatrics, as I mentioned too, then, and in the adult world when your caregivers disagree with your decision. And so that's another great way for palliative care to be involved, as another group listening and thinking with that individual about their hopes.
Can I add in something real quick? I remember the first time when Dr. Euler and I sat and talked about transplant, I said to him that I will do this, that I want to do this for my family. And he looked at me and he said, this is your decision, and you need to decide this for yourself. If you want to do this, you have to do this for you. And it was very eye-opening to me that I'm really the one who's going to go through this and have to take it all in and be strong enough to endure it. And that's when I took that thought and I went back to my palliative care team, and that's when we had extensive time and we just sat and thought about this and worked together for me to finally come to that end decision that I did want to do this and that I was going to pursue this for me, to hopefully give me added time here with everyone to be able to make a difference in the lives of others.
So on point, so valuable, just to sort of hear your perspective, Nora. To go to the next question, Dio, I'm going to look to you to start us off here, but this is about sort of the guidelines being developed in this era throughout this conference, right? We're hearing all about modulator therapy. And Elizabeth and Mary Beth sort of commented some on that in their talk, but this idea that these guidelines were developed just before the widespread availability of Trikafta, wondering if we can comment on sort of how we now look at this and our guideline and the recommendations, and would anything need to be reconsidered in this era, or do the recommendations sort of still stand and sort of hold true?
This is a great question, and I think one that we could spend an entire separate symposium on really unpacking. But I think what I would point to is sort of remembering the spirit of the recommendations, that palliative care isn't something that should be tied to prognosis or when our treatments fail people living with CF, but rather palliative care is likely relevant and appropriate throughout the entire CF experience. As we've talked about, modulator therapy has brought so much hope and optimism to our community. And yet we also know that modulator therapy probably doesn't reverse existing lung damage. And so it's likely that palliative needs will continue to exist and evolve over time. And I think that's why in the guidelines, we stress being vigilant for palliative needs over the entire course of illness, and not just when things are not going the way we want them to. I think one thing I'll add is that some folks may feel uncomfortable approaching things like goals of care conversations in light of modulators. I think that clinicians in our community may benefit from skills and some example language to use when broaching goals of care discussions with people living with CF who are on modulator therapy, and conversations that acknowledge and leverage the hope and optimism that people may be experiencing from modulator therapy, and also recognizes the uncertain course of illness, and as well as other evolving palliative care needs over time. And I will say that guidance and that exemplary language is something that we're working on at the foundation, so I would say stay tuned.
I think that's right, stay tuned. And also there are, in the guidelines, there's a whole table of resources that you can look up for different places to sort of further some primary palliative care knowledge and education, as well as at my.cff.org. There's a palliative care toolkit that has a user's guide with additional sort of resources, should you be interested. Speeding right along, because you keep asking great questions, everyone. Thank you. This next one, I might start with maybe Jessica and Mary Beth, but we don't have outpatient palliative care specialists in our area. This leaves us hesitant to screen for needs if resources to meet them are limited or non-existent. And so what strategies or thoughts might you have for somebody in that environment or predicament?
I'm happy to start out with that one. For one, I think that it never hurts to know more about the person in front of you. So I would never decide not to screen based on limited resources, because we as teams will provide better care of that person in front of us if we know more about what they're going through. I think the other thing I would want to emphasize is that for many, many years, our entire careers in CF, what we have primarily been doing is primary palliative care, just like Dio had talked about in our first talk. So I would just encourage us to, always think of the whole team as providing the care. And when we're referring to palliative care, we're not referring out to somewhere else. What we are doing is bringing that other team into the fold. So we should always, phrase it as we're bringing others in. So just because you don't have that palliative care specialist, I would still screen, again, because knowing more about that person in front of you, you will be able to provide better care, and so will your colleagues. Mary Beth, what are your thoughts?
Yeah, well, I should say you stole my answer, but I have a little more to share. I think, we thought about this a lot, or the foundation, mental health providers did. We started screening for mental health needs, right? And wondering about, I'm trying to remember, there are 100 counties in North Carolina and maybe 30 plus don't have mental health providers, right? And so what are we going to do when we find these needs, or what are we going to do when we're really worried someone's suicidal, right? And we have a real safety concern. And so there was some thought before we screened about what is our plan going to be. So I think, you could have some pre-thought prior to screening, but I also agree that it's important to do a holistic, evaluation or conversation with someone, especially when we're thinking about palliative care. I think in mental health, for example, I sometimes get overwhelmed even with how many screeners do I use, and I better check this one off. But having a good discussion pulling from some of these areas, I think, could be helpful if you decided I'm going to really focus on symptom management and think about what resources I have related to symptom management as a place to start. And again, just to repeat what Jessica said, reminding everyone that you are primary palliative care providers already. I am a psychologist with the CF Center and also a palliative care provider. And I joke sometimes, I don't know what I'm doing, right? Because I feel like I'm doing a lot at the same time. And so just remember your skills that you have and how you can integrate them and how they align with these things we're talking about.
I think what you both just so eloquently sort of explained reminds me what Noor finished with in her talk, which is like, don't underestimate the importance or value that you have sitting and working with the people in front of you, and how even small acts of being curious and open and welcoming can really make immense differences. This next question may look to Amit and Noor to maybe start us off with, but in light of Noor's powerful story, any tips for palliative and other CF care team members to be mindful of during times of transition between pediatric and adult care? So thinking about transition as really a formative time in people's lives with CF, and sort of also potentially a time of being vulnerable for palliative care needs. So any tips or advice that you would have for care team members?
Or do you want to go first this time?
I was thinking deeply about this one, and over here in Boston, we're lucky that our children's hospital is connected to the Brigham and Women's just by a bridge, and so it's very easy and accessible to get to both. And something that I think that's so important in the transition process is to have some kind of follow-up, and also to try and possibly maybe have the transition process be done during a time that the patient is stable. And sometimes when a patient is stable, you don't necessarily think that they need to be seen by palliative care or have these kinds of teams be involved maybe in the moment. But just with my experience where my transition was in a time of crisis, it just made things so much harder. And I wish that maybe I had met the palliative care team over at the Brigham and Women's Hospital beforehand, so that I was maybe a little bit familiar with that and with them. And I think that's something that would just be so helpful, is to have maybe a stronger communication between both teams, even after the patient is transitioned over to the adult setting. The adult setting is very different than children's setting. And I know that that things are getting stronger and better in the palliative care aspect now as the Brigham and Women's Hospital since my experience a few years ago.
Yeah, no, keep going.
No, go ahead.
I mean, you were saying that so perfectly. We just had a transition conference just last week where we spoke to this, and also since Noor, we have actually a pretty, a process where transition is individualized, and it is done during a period of, as you said, stability and over time. That is not just a transfer that happens overnight like it did in that time of necessity for you. And so that does make it so much harder. So that is absolutely correct. Go ahead, Noor.
No, I mean, it's hard. It's always hard. Change is always hard. But I have come to learn that change just means there's room for growth. And I think that having had such a strong bond and such great care from palliative care over at the Children's Hospital, I truly hope and wish that there can be a palliative care team in all hospitals that can be have that strong relationship, because I just think it's so important for all of the patients to have those connections where they are able, like Elliot said a little while before, like that you are able just to give those, sometimes just those small extra moments you can gather the most valuable information from, that can then help the patient move forward in the best way possible, whatever that may look like.
I would just add that the handoff, we already knew Noor, an adult team was already part of Noor's care. So it was the warm handoff from palliative care to palliative care team was where this was a struggle for you, right, more so Noor. So, but each team really handing off to another empathic, team taking over is really critical.
Thank you both. I mean, I think that, again, sort of really highlights, that open lines of communication, especially during those at-risk sort of time periods or more complicated sort of time periods, are just so important amongst different team members. I'm mindful of the time and don't want to do a disservice to sort of some of these questions, because as many have focused, we could talk for long periods of time. We have about a minute or two left. Elizabeth, want to, in 1 minute, sort of briefly touch on this idea of how to reduce suffering when sometimes they're working in challenging scenarios, say adult patients who may have pain medication-seeking behaviors or other sort of psychosocial sort of challenges?
That's a
Hard to
pretty good
address it in a
question
minute.
Yeah, we got this all figured out, right? Yeah, I mean, right. Life is hard, and having a chronic health condition is really hard. On top of life being hard, and a lot of things happen to a lot of people that inform, difficulties in their lives. And I think everything just comes down to communication, support, open-mindedness, really a willingness, and to not only to partner with people with CF and their caregivers, but to listen and to support in a meaningful way, and to engage people with expertise. So if we're talking about something like a serious mental health issue, we really need good communication and partnerships with mental health specialists. If we're talking about a substance use disorder, most of us don't really have a lot of experience actually, certainly managing, but actually partnering effectively with people with a real range of challenges in that area. So we need expertise and support sort of brought in. I loved how you said that, Jessica. We're bringing in, as the CF care team, people that can help sort of navigate challenges and really support our patients and families in the most effective ways possible. So that's not at all a specific answer, but I think communication and partnerships are key.
Perfectly highlights the themes that we have been all talking about here. Again, just want to thank everybody for coming and attending this symposia today. Thank the speakers, particularly just want to highlight Noor. I think hearing your perspective and experience here is just truly invaluable. And so thank you, everyone. Please feel free to reach out to any of us through the portal communication chat if there are follow-up questions.
Thank you so much for having us.
Thank you. And thank you to the foundation also for continuing to highlight palliative care in our conferences each year.